There always was an ambulance transport system, but it wasn't staffed by EMTs. It was originally staffed by a driver who drove a hearse from the mortuary, and that slowly evolved to a unit that could house a gurney and sometimes an attendant in the back, but they had no training, no medical training at all.
It wasn't until the early to mid-70s that they realized that we had to do something different.
They developed the Wedworth-Townsend Act, which allowed counties to establish paramedic programs.
When they actually launched care providers, physicians, nurses from the hospital-based arena. It was at that point in time in the evolution that they realized, hey, fire service is already positioned for response to fire suppression to be also rapid response for to provide EMS care.
The fire department started training their firemen first as EMTs and then as paramedics. But there were no certifications. There was no quality control to ensure that people were doing it right or the same. As the program got more known, the call volumes went up and the demand became greater and greater. So paramedic training started at UCI Medical Center.
And it shifted to Saddleback College.
And we did it there and only trained fire department personnel because all paramedics in Orange County were firefighters first. There was much skepticism, especially by the physicians involved, who definitely thought that only a physician or a registered nurse should be poking people with needles or giving people medications.
There is virtually no independent functioning of the medics at all.
Slowly, paramedics proved that they did exercise excellent judgment and that they did demonstrate outstanding skills and gave them more responsibility for making decisions as to when they needed to consult with someone of higher medical authority. So that took about 20 years.
Not all of our firefighters are paramedics, although quite a few of them are, just under 400 now on the active roster. Over 50% of our calls are handled first strike by an ALS unit. So that means a fully staffed two-person paramedic unit. And a varying percentage of other calls are handled by basic life support. Orange County still deploys 2 paramedics as an ALS or a paramedic team. We do have units with a single paramedic on board. We call those paramedic assessment units. The idea there is to get a unit on scene as quickly as possible with a trained paramedic to begin a detailed evaluation and perhaps start treatment of that patient as needed using paramedic level skills. We have 4-person ALS engine companies with 2 of the folks being trained to the basic life support or EMT level and 2 as ALS paramedics. We also have paramedic vans with 2 firefighter paramedics on board. We have truck companies that have a single PAU paramedic, or they have an ALS truck company down in San Clemente. So Orange County Fire Authority has embraced the wide multitude of deployment options to try and meet the unique needs of the citizens.
When Orange County Fire Authority receives a 911 call, the call taker in the Emergency Command Center, or ECC, confirms the address and phone number and quickly finds out what the main problem is. These 3 bits of information are all that's needed to create a call for service in the Computer-Aided Dispatch, or CAD system. Creating a call for service usually happens within 30 seconds of the dispatcher receiving the 911 call and allows the call taker to quickly send the call to the dispatcher. During this time, the caller can continue describing their situation, and the call taker can type this additional information into the CAD system. Based on this information, the CAD system recommends the closest available units, and the dispatcher then dispatches the call. Based on the information gathered from the caller, the medical needs of the patient are determined and classified as needing either basic life support, or BLS, which encompasses traditional first aid, or advanced life support, or ALS, which requires paramedics. If BLS care is needed, ECC dispatches the closest single engine or truck consisting of 3 to 4 firefighters trained in first aid and a private ambulance. If ALS care is needed, the closest ALS paramedic unit is also dispatched, which could potentially result in there being more than 1 OCFA apparatus present at a single medical aid. OCFA carefully monitors response times, and within 2 minutes of the dispatch, the assigned units will be en route. The assigned units are notified of the incident when they receive all incident information and text on their mobile data computers, or MDCs, their pagers, station printers, and via verbal dispatch over the radio system. To ensure the patient receives the appropriate care as quickly as possible, several things happen simultaneously at this point. The units are notified of and respond to the incident while ECC provides medical instructions to the caller over the phone, beginning the first phase of patient treatment. Through the MDC, the crews obtain the patient's emergency complaint and location, information pertinent to the incident, and are notified of any changes such as deteriorated status or initiation and progress of CPR. Meanwhile, in ECC, the dispatcher uses a handbook called the Emergency Medical Dispatcher, or EMD, to ask the caller questions and provide instructions to assist the patient with their specific medical condition or emergency. If the information obtained by the dispatcher over the phone indicates that a different level of response is needed, ECC changes the response to meet the needs of the patient or emergency. When the BLS unit arrives on scene, they perform a basic life support medical assessment to determine whether the patient is stable and considered a basic life support patient, or if the patient is critical and requires advanced life support. This assessment is determined usually within the first 5 minutes of the first unit's arrival. If it is determined that the patient needs to be transported to the hospital, the ambulance that is dispatched along with OCFA units will transport the patient. Once the patient has been assessed and treatment has begun, the patient is moved into the ambulance for transport to the closest appropriate hospital emergency room. While en route to the emergency room, the hospital is notified of the patient's medical emergency, status, and estimated arrival. If the patient is considered to be BLS level but still needs to be transported to the hospital, the ambulance crew takes over care of the patient from the scene to the emergency room. OCFA paramedics remain with the patient in the ambulance only with the ALS level patient to provide continuity of ALS treatment from the scene to the emergency room. If this is the case, the OCFA unit in which the paramedics arrived on scene will follow the ambulance to the hospital so they can pick up the paramedic. Via radio, the paramedic initiates direct communication with a specially certified nurse or doctor. They provide constant updates of the patient's medical information to the hospital and receive treatment orders while on scene or en route to the hospital. While this provides the ER with a constant update of the patient they are about to receive, it also ensures the patient is continuously receiving the highest level of care possible until they arrive at the hospital. Once the patient and ALS providers arrive at the hospital, they will turn the patient over to the RN or doctor. This quick change of hands helps to ensure the ambulance and fire crews are available as quickly as possible. Before they leave the hospital, all equipment is sanitized and prepared for the next incident. ECC is notified via MDC or the radio once they are available and ready to respond on the next call.
As the EMS Battalion Chief, I oversee several areas of responsibility, including the maintenance of training for our paramedics, our EMT providers, our dispatchers. I also work closely with the ambulance companies, our private providers, in providing service out there. We use private ambulance companies to provide transport to patients as a result of a cooperative agreement between the private companies and government agencies involved. And it works out to be a great public-private partnership, and I think provides exceptional care to the folks that need it when they need it. The ambulance contract process has evolved greatly over the last several contracts. And currently I think we have a great contract that gives all of the people out there great service. Our current contracts are active contracts. We have one that started in 2004 that was supposed to last 5 years with a 5-year extension option based on the awarding authority. And several cities took that option, and so they're still operating under the 2004 contract. We did go to RFP and issued that latest contract at effective September 1st of 2009. 10 of our cities are operating under that new contract. In 2014, we will renew all 19 of our exclusive operating areas. The State EMS Act allows the county to establish exclusive operating areas for ambulance service. The idea there is they can combine areas that have low populations with areas with high population densities and kind of combine them together so that one provider can provide coverage to both areas, and with the idea of equalizing the coverage, to having good quality coverage in those low-paying areas as well as the high-paying areas. The County of Orange has established those exclusive operating areas, and Orange County Fire Authority has 22 of those areas in our protection area. 3 of those 22 are serviced by and administered by city administration. 2 of those have elected to provide ambulance service through municipal ambulance companies, in this case Orange County Fire Authority ambulances. All the rest of them, the other 19, are serviced by private ambulance providers. Awarding exclusive operating areas for ambulance service benefits the public because it allows a single provider to provide service in that area. That way the provider knows what the service requirements are, they can staff up appropriately and do a better job of meeting the needs, whatever those are, of the citizens in that area. If it seems that the patient just needs basic life support, which is EMT basic, then we'll send a basic life support unit to that call. We'll also send an ambulance at the same time. The ambulance goes code 2 without lights and siren. If it's later determined through further information that the patient really requires paramedic service or advanced life support, then the call is upgraded and an ALS or paramedic unit is assigned, and in some cases the ambulance is increased to code 3. When the crews arrive, they'll further evaluate the patient to determine the level of care needed. If the patient only needs basic life support, but yet they still need to go to the hospital, then the patient will receive a bill for that service provided by the basic life support ambulance, even though no fire department paramedics ride along with them. OCFA doesn't charge just to show up and evaluate. If the patient also needs advanced life support or paramedics to go in with them and continue care all the way to the hospital, then they'll receive that bill for basic life support transportation and in addition an advanced life support fee. They'll only receive a bill from the ambulance company because in that case the ambulance company works as our billing agent. The ambulance rates are determined and set by the Board of Supervisors. They determine the basic life support, the cost for mileage, the cost for oxygen, the allowable charges for consumable supplies, and they also set the advanced life support rate. Some of that fee is sent back to us to help offset the costs of delivering that advanced life support program.